Hey, everybody. Wanted to talk about risk submissions today. I know that the deadline for all in for 2022 dates of service is going to be January 31st. That falls on a Wednesday, 8 p.m. Eastern Time, when health plans will have to have everything submitted to CMS. Now, I know a few of us in the industry, fingers crossed, are hoping for a Valentine's Day gift and we might get an extension. Going to cross fingers 2 times and all other appendages that we get a little bit of an extension, but want to remind you that you do not have that extra period that was created by the public health emergency to do your submissions. And so anything that you need to submit for 2022 dates of service needs to be in by January 31st, 2024, 8 p.m. Eastern. Now, that's the deadline for health plans. But if you are a risk-bearing provider group in Medicare Advantage, you probably got earlier dates, and that's because it takes time to process your files. But what I would suggest is that you work with your health plan partners to see about getting those dates extended if you need them. A lot of times, having worked for risk-bearing provider groups myself in the past, have been able to get some of those deadlines, some extensions, but the absolute drop dead door is shut date that CMS has indicated is going to be that January 31st deadline. But do stay tuned because we never know. And those stranger things, I've been around long enough in the industry to know those stranger things have happened and they have granted extensions. And just knowing that this is the first time since the public health emergency where we won't have that summer submission, that maybe we'll get some grace. So the thing that I wanted to talk about today was around physician specialty type and the difference between billing and rendering provider and how that could potentially impact your risk adjustment program. A lot of times, because we have been such a claims focused industry in the past, and makes sense, right? Patient sees you, you submit a claim, you want to be paid, the health plans reimburse on those. Folks have focused on the billing provider, and that's what was important. And a lot of times that's an entity. It might not be the same as the rendering provider. And let me tell you why that's distinct and why that is so important when you're thinking about your risk adjustment submissions. It is required that the rendering provider be of a certain level of credential or license in order to attest or diagnose and provide a diagnosis that could potentially relegate to having a risk value. In risk adjustment, that's always been nurse practitioner and above. So typically we think of nurse practitioner, physician assistants, MDs, DOs, but there are other specialty types that can submit diagnoses for risk, and I'm going to share that with you. It changes every year, so it's something that you should be aware of, always looking for the updates, making sure that if you're doing any type of program, be it when I think about education programs or I'm thinking about retrospective chart reviews, I like to think about who is the rendering provider. If I'm doing a retrospective project, we're only going to pull those things for submissions that will risk adjust. Now, rendering provider, when you think about it, it's the provider that rendered the services. It could be the NP. It could be, in some states where NPs are still required to be supervised, the physician of record is supervising, but it's really going to be who signed off on that note. I want to remind you too that whenever you're providing signature on a chart, it should include the credentials of that person or that clinician that's signing the note. But you want to make sure that you have documented in that EMR or in your submissions the rendering provider. I've seen a lot of EMRs in my time or even submissions that were set up where the billing provider for ease was mapped into the rendering provider space, or not even the rendering provider wasn't even provided at all. And that's a problem because if you are not reporting the correct rendering provider, one, it's exposing you to audit because they're going to see you have a mismatch between who you said rendered the service versus who actually did. And then two, why it's important is that billing provider could be an entity. It might not be tied to an appropriate MPI. And if that's the case, it wouldn't be recognized for CMS. So you could submit all the data that you wanted, but if you don't have the appropriate rendering provider ID listed in the appropriate place and going over, and again, I've seen file submissions where they're only including the billing provider ID or they're mapping the billing provider ID into the rendering space. And I would not recommend that. I would recommend that you have the appropriate rendering provider ID so that you are sure that any codes that are captured, that burden of illness that's captured on your patient, is being attributed and recorded appropriately. Now, let me show you what specialty codes are risk adjusting for 2022 dates of service and that 2023 payment. Okay, so this here is the acceptable physician specialty types for 2023 payment year, and that's 2022 dates of service. So again, want to remind everyone, the deadline for 2022 dates of service, that means you saw the patient in 2022 from January 1st all the way to December 31st, 2022, nothing outside of that. Those dates of service need to be submitted by January 31st, 2024. There will not be an extension, at least that we know of at this time. And the appropriate specialty types that are acceptable for risk adjustment, I'm going to look at my big screen because I'm old and I need a bigger screen. You can see here the listing: general practice, general surgery, jumping down 68, clinical psychologist. You can see pain management, number 72, even D5, opioid treatment program. All of these provider specialty types, any diagnosis that comes out of that medical chart that is signed by a physician or clinician that carries these credentials would be acceptable for risk adjustment. And so when thinking about your Medicare Advantage programs, I know we're talking about submissions. I always think about my submission types, again, making sure that I have the appropriate rendering provider listed and the appropriate specialty code affixed to their presence in my EMR. But in addition to that, think about when you're running any of your programs, there might be certain specialty programs that you want to run around education. Maybe you want to work with your podiatrist. Maybe there's an opportunity to work with the clinical psychologists that are within your network. All of these provider specialty types here permit you to capture, or they're permitted to capture, risk adjustment. Now, the other thing that you could be thinking about too is retrospective chart review. And every year I look at what my pull list is going to be around my specialist. I'll do this in another episode, but I typically do 100% PCP, and then I do a claims based on my specialist and on my hospital claims. The thing with this specialist table and why I think this is so important is sit down with the clinical folks in your organization that understand risk adjustment. Sit down with those super smart coders that you have on your teams and talk with them. I used to always sit down I had this super stellar coding manager. I hope he's watching. But we would sit down and we would talk about where codes might be captured and be duplicative, right? You would see it, say, in a pain management chart, but also in another chart. And so it would allow you to prioritize and strategize exactly what you needed to pull for specialty, especially because I know budgets are tight, but this is one way that you might do it. And so knowing that these are all the specialty types that risk adjust, you might take out any specialty that doesn't when you're doing your retrospective program as a way to strategize and prioritize monies. Not that the records aren't important, but they might be captured elsewhere, and it's a way in which you can be really targeted with your dollars. All right. So again, I know I keep saying it, but make sure that you have all your data together. Everything is submitted for 2022 dates of service by that January 31st deadline. And then if you're a risk-bearing provider entity, be working with your health plans. If you've been good all along and comparing your MAO4 files or your CCLF files, if you're ACO REACH, ensuring that data has been picked up by CMS, fantastic. But if you're seeing a gap, one of the reasons for that gap may be because you have either a mix-up with a rendering provider or you don't have the appropriate specialty type, these risk adjustment or risk adjusting ones associated with a rendering provider that's on that record on either that claim, that encounter, that chart note that you're submitting to your health plans or to CMS. And so those are some opportunities for you that you might take a look. If you still have questions or you would like help with any of this work, know that my team and I are available. Have done this work quite a bit in the past across the industry and so happy to help. Reach out to us at info@vbc1.com. You can check us out on our LinkedIn page and reach us that way. You can direct message me here. You can also reach out to us on our website. All right. Good luck. Good submitting, and hope that you get everything that you are expecting and that you deserve in order to care for those patients. Thanks so much.